we still have a gag clause where we can't come out and say bad things about the PBMs, or we can't inform on the PBMs. They will come out and they will take our network contracts away. And so you'll lose a huge chunk of your patient base.
Hello, everybody, and welcome to the HeyRx Friends We Got This podcast, where we share our thoughts on the pharmacy profession, experiences as healthcare providers, and explore our identities as women of color going after it all.
As we share our stories, we hope you laugh, maybe cry, and feel inspired as you get to know us. And remember, at the end of the day, friends, we got this.
Yes, hello, everybody. Welcome to the show.
Hello, everybody.
It's been a while since we...
I haven't seen Thu's face in a little while.
Yeah, it's been almost a month since we recorded an episode.
But the
last episode that we recorded, we did it in person, and that was really cool. And we actually have a guest today, if you guys are listening on Spotify and can't see him already. But we have a very, very special guest, and I'm so excited because this, I think, is a highly anticipated episode. I think a lot of people have been requesting for this, and I felt like instead of me doing all the research about PBM, which I'm not an expert in anyways, and
boring.
Boring and also a headache for me. We just thought, why not just ask an expert to talk about it for us and just break it all down? And I feel like we found the perfect guest. The perfect guest.
And the reason why I'm excited about this guest is because, I'm all about serving it up straight up, no ice, no chaser. And that is what we need. That is what we need around this conversation to wake everyone the hell up, because we've been sleeping.
I've got a little ice right now.
Yeah, right. A little ice right now. It's like,
it's game day.
It's game day, right? Like without further ado.
So, Jeremy, could you please introduce yourself and tell us a little bit about your background and PUT and how you ended up on this podcast?
Yes.
Yeah. Well, I'm Jeremy Counts. A lot of people know me as Hokey Farm on social media. I am on the executive board of PUT. I'm the host of PBM on the Rocks podcast, which, if you've not seen, is a lot of drinking and cursing, but it's really popular, which is weird. I'm a second generation pharmacist. I'm a pharmacy owner in Blacksburg, Virginia. I obsess about my mediocre college football team. My pharmacy is 2 blocks from campus. I got involved with PUT whenever I was out and I was getting more active and talking about low reimbursement and how it's hurting pharmacies, because I've been seeing it for years. I grew up in a pharmacy in like the heyday, back when drug prices were manageable. People would actually just straight up pay for out of pocket just to have brand name medication instead of the other. Things started really going sideways after Medicare Part D and then the ACA, just because a lot of it, there was a lot of vertical integration and it kind of encouraged that. And that's something we've got to dial back, but I'll get into that later. And so Scott Newman, our former president, he found me and he was like, this guy. And so they brought me on, and man, you talk about learning some stuff. I didn't get as active as I am now for about 2.5 years, just listening to the board and listening to things that were happening in the background in advocacy, all the internal politics, everything else going on. And then we started doing PBM on the Rocks, because I do a lot of sports podcasts and sports radio and stuff here for Virginia Tech. It's just fun.
Yeah.
And in that, I had a tendency, whenever they bring me on, I would get, I'd get fired up and I'd drink and I'd start going on and curse and do all the Jeremy shit. And I would do that, and it was fun. And I kind of brought that over whenever they did a PUTcast episode. And it was the only PUTcast they bring on politicians, they bring on everyone else. On this one, they brought on Jeremy, and it was the only R-rated PUTcast ever. And so we had a good time, and PBM on the Rocks just kind of came out from that. And after we'd been doing it 6 months to a year, it just started exploding, because I would get on and I'd do all of these things where I would go on my rants and we'd talk about what's going on. And it tapped into a lot of the frustration that pharmacists are feeling right now, and it resonated with them, and it kind of blew up from there. And that's been a really good platform to get the word out on what is happening right now, tactics that PBMs are using to undercut pharmacies, and what they're doing to the profession as a whole. So it's been a fun journey, and I got on and I was on LinkedIn, and I was trying to get some podcasters together, because with the sports podcasts, we do a lot of crossover where we bring on guests from other podcasts, and it's great because we all get together and we're all friends and we have these joint episodes, and it's been really good for everyone's podcast. It's good exposure. It's also a good way to show everyone, like, hey, we're a family. We're all in this together. We're having fun. And so I was like, why don't we do that for pharmacy? And I got on and I talked to Mike, and then I saw your all's housewife sketch, and I went, oh,
you saw Thu's. You saw Thu's. I refuse to take credit for the housewife sketch.
Now, but Sally's getting more involved. And actually Jeremy's a big part of the housewife skits as well. Behind the scenes here.
I know, like, she's got all these behind the scenes producers. And she's like the actress. I get like giddy every time there's a new one dropping.
Yeah, every time there's a new one, it's gotten more complicated. And so I reach out to the experts in the field. I'm like, can you fact check me? Like, I don't know what's going on.
That's what happens. It's a complicated industry, and it's purposefully that way. They actually call it MEGO in financial. Because it stands for my eyes glaze over. It's intentionally misleading and complicated. Yeah. So that regulators and policymakers, they can't actually see what's going on. They just kind of tune out. And it's like, okay, whatever. And that's been on their side forever.
And so, sorry. Go ahead.
Well, I was going to say, before we jump into all of that, let's be good podcast hosts and introduce ourselves. So my name is Thu.
If you can figure it out, I'm Sally, everybody. I'm sorry, everybody.
And we're so happy to have us.
Jeremy.
Jeremy Counts, yep. Before we jump right into all the nitty-gritty topics about PBMs and the business of pharmacy, really, if you are watching on YouTube, please like the video, subscribe, and write in the comments what you think about the topic today. If you're listening on Spotify and Apple Podcasts, we would appreciate if you leave us a review or rate us. That's really important, I think, for the growth of the show. And also what's really important is for you to share this episode. And I think this is going to be an incredibly important episode to share. So like, get your finger ready to click that little arrow and send it to all your friends and to your mom and your dad and everybody who uses medications, because honestly, I do see this episode as something, as a guide for people, not just in healthcare, not just in pharmacy, but people who are just randomly on YouTube and click on a random video that talks about why their prescription costs the way that it costs, and why are things feeling so much heavier and tighter these days. So I'm hoping for this conversation to be expansive outside of healthcare, outside of like our normal audience as well.
Yeah. Absolutely. I'm just eager to get into all of it. I think like Jeremy's introduction has touched on something too that is very true and dear and authentic to us here and our listeners, that I just wanted to accentuate a little bit: the power of authenticity. Like, he didn't step into the PUT space and was like, okay, I'm going to be talking to pharmacists. Let me button up. Let me straighten up the language. He brought the Jeremy energy, and he's like,
that ain't me.
Right? Like, he's like, I'm used to going on this other thing. There's beer, they bring politicians, and then they brought me. So it's like, it just sounds like there's like energy, and then there's Jeremy energy, and like bringing that and being able to bring attention to something he's incredibly passionate about, that's been able to work. Back to our message on this podcast, the fact that your PharmD can absolutely coexist with everything else you are and everything else you're passionate about. That's my soapbox number one for this episode.
Soapbox number one. I have a feeling there's going to be many other soapbox moving forward. Yeah, but before we,
and that's important. That's why I'm so grateful to PUT for what they did, because I'm not the kind of person that could go into a lot of national organizations and them give me that kind of platform, because I'm not buttoned up. I never will be. That's not who I am. So PUT gave me that platform because, I mean, they fit with me. And one of our biggest things that we're doing right now is reaching out to pharmacists and trying to give them a platform and trying to give them a way to channel their energy and teaching them how to advocate and teaching them how to talk to lawmakers, because that's increasingly important right now. If you go into a lot of national orgs, I mean, they're going to fight for you, but they play by the rules.
Yes.
I do not. But we increasingly got to be, careful. We've got a lot of eyes on us, but we fight dirty. And that's why I put it at the end of my tagline, be loud, be fearless, fight dirty, with every article I write.
Yeah.
Love it. I love it. Well, Jeremy, what should the first question be? I guess if I was just a random person and buying prescriptions, I would say, why are prescriptions cost the way that they do now? Can you break it down for the typical listener? Like, what is going on? Basically,
I can. It is a complicated subject, but we're going to take the big, bird's eye view of it. What happened was, back in the day, you had your health insurance, and it didn't really do much as far as prescription benefits. And when it did, they didn't have anything internal to really take care of prescription benefits. We would just have to hand bill, and that's the way it would go. Patients would pay out of pocket, they'd turn in a claim, and then they'd be reimbursed by their insurance. Well, increasingly that became a burden, so PBMs popped up to manage these prescription benefits for employers and the insurances, the plans, and so that's what they did. Well, going forward, they had a bit of a business model where they got a kickback exemption in the 80s. And that kickback exemption was to keep the price of drugs down, especially brand name medications. So they were able to extract kickbacks legally, and they're called rebates. These rebates, they're titled rebates because it sounds better than kickbacks, but they're straight up kickbacks. And what happens is you have drug manufacturers who will pay a rebate to the insurance company to be placed on a formulary so that it's covered. Increasingly over the years, we saw that the list price of medications, which is what we all pay if we don't go through their little coupon club, it was raising up like way and way, way more. That's because they were paying increasing amounts of rebates to be placed on formulary. There's a misaligned incentive there. While that's happening, the PBM is also taking a percentage of those rebates through themselves, their group purchasing organization, which they've now offshored, by the way. And they're keeping a lot of the net pricing discount, and it is making you either pay a ton of money out of pocket to get these drugs, or you have to join their little club. Now, if you join their little club, they have numerous mechanisms to profit off of you as a patient. A lot of times you're paying more out of pocket for your copay thinking, oh, it's much cheaper, but it's actually higher than the net cost of the drug. And there's a ton of rebate money in between. So they have artificially inflated the cost of brand name drugs over the years with these rebates.
Yeah.
That
Can we break down
Yes,
something?
go ahead.
Because when you say rebates and kickback, in my mind, I still don't quite understand what that means. So let's just kind of
set up a scenario,
break it down a little bit more. Like, I am the drug manufacturer and I go to you, the PBM, and I say, I have this amazing drug. It's called Thu. And I think that we should have her on the formulary. So to have
Thu, it's a new drug. It's got competitors, right? All right, well,
Saleh.
How much are you going to offer that drug for, Thu?
Oh, see, okay, so Saleh could be my competitor. Okay, so I would say, how much would I offer you to be on the formulary?
No, how much are you going to sell your drug for?
Okay, I'm thinking $100 per bottle.
$100? Shit, Thu. We're talking bullshit here.
What?
No. Saleh's got a drug over here that has a list price of $600, and she's offering me a $510 rebate. Why the fuck would I cover your drug? You need to jack that up to $600, and give
and give
me
me
an increased rebate. Once you do that,
you're telling me to increase my pricing?
absolutely. If you don't, I'm not putting you on formulary.
Weird. Wait, what? I just thought the drug manufacturers think that they're the ones making the decision to increase their price because you guys are
That's
asking.
what they want you to think. Don't get me wrong. Drug manufacturers have benefited in some ways from this arrangement. They absolutely have.
Yeah.
But it's increasingly becoming a problem for them because they are a very easy target and have been for years. Yeah. Don't get me wrong. There are a lot of sketchy manufacturing processes. But when it comes down to the actual cost of drugs, whenever most of it is going in to the PBM and getting kicked back to like large employers or plan sponsors, and they're keeping a big percentage of that, that's the biggest driver of list costs.
Yeah.
There's no way to argue otherwise. Mm-hmm. And so it's almost like extortion in some ways when it comes to the rebate scheme. And that's why rebates are outlawed all throughout, I mean, every other industry except this.
Yeah. Did you know that? Yeah. Did you know that? Like
Yes, they have a kickback exemption.
Yeah.
That's wild. That is so crazy.
Insanity. Yeah. Like the things like the point that Jeremy is making where here you come, you think that there's a gap in the market for where through 10 milligram can nicely come in and help patients. You want to make that affordable. You're coming to Jeremy with an offer to be on his shelf for $100. He's like, yeah, that sounds great. Sally at her 200 milligram with a gang of side effects, I get like $510 from her, and she's going for $600. She's more expensive for my patients, but I make way more money off that than your thing that can help and is cheaper. Let's elevate this conversation. Make yourself $620. Maybe we have a deal.
Yep. And you'll also see, you'll have new classes of drugs come in that are way better. And these drug companies, they know they're better. Like this is the drug. They'll come in, and if they don't pay the PBMs enough, the PBMs are going to require you to go to very outdated drugs and try them before it gets covered. So it works so many different ways.
Yes. The tiers. And I want you to right click right there for a second. So Thu decides this is unconscionable. I'm not doing it. I'm not raising the price. I know my thing is better. I know my thing will work. And I know my thing is going to expose patients to less side effects. This is the thing that makes sense. $100 is my offer. You say, sure, no problem. But what are all of the strategies that are in place presently that Thu's drug will probably have to go through before a patient gets access to it?
Thu would have to straight up sell it, and it wouldn't be covered on a lot of insurances. It would get lower tier so that it wasn't actually covered. Thu could offer a smaller rebate and they'd put it on a low tier. They'd make patients pay more out of pocket. But here's the thing, a lot of patients that need these medications, they're either low income or elderly and low income. And so you exclude yourself from a huge part of the market when you don't increase your list price to pay these rebates. Because whenever Part D was put in, it kicked PBMs into overdrive, full-on overdrive. And that's when they really started under reimbursing pharmacies, and they really started kicking the rebates into high gear. Because when you have a ton of government money flooding in, there's going to be profiteers. The thing is that's good to have in a lot of ways because you need to take care of people. But whenever it happens with little to no oversight, that's when the problems arise. And that's what's happened throughout the years. And it became worse whenever the ACA was passed because the intentions of it were great, but what happened was there was a medical loss ratio on the insurers. And so they could only make profits on, 20%, which in pharmacy to us seems like a whole lot because we don't get that. So they could only take 20% of profits. And so the response was, hey, PBMs are making a killing. Vertical integration. So PBMs who are supposed to negotiate with the insurers, the drug manufacturers and pharmacies, they end up becoming a part of the actual plans. And so you have this outsized advantage with the vertical integration. And so now they started squeezing pharmacies even more. And they're demanding even higher rebates from the manufacturers. And so they have leveraged their kickback exemption and their vertical integration to apply pressure up and down the entire industry. That includes other health plans that are trying to compete. That includes other PBMs that are trying to compete. And that definitely includes non-PBM owned pharmacies, where they will under reimburse us, especially an independent, which we saw in the 3-axis report, while paying their own pharmacies a huge amount of money. So a lot of times you'll see them offload a lot of their margin onto the PBMs, that branch, because it is so opaque, they can hide a lot of that margin.
Yes.
And they can use a lot of misleading metrics to make it look like, oh, well, we're saving money.
Yes.
And so it's a lot of profit hiding.
Mm-hmm. And I want you to explain a little bit, because when we say vertical integration, those of us that are like AmCare or outpatient, and we understand what that means, but I'm thinking about our listener that's probably not in pharmacy or is a nurse or is a first-year pharmacy student. What actually happened?
Or is an inpatient pharmacist and doesn't have to deal with any of this?
We're like
formulary? Right, what is she?
Let's break it down.
Who's her?
Up here we have the employers and plan sponsors and everyone else. Then you have the PBM. Then you have us, the pharmacies. And that's the simplest kind of chain there.
Yeah.
Off to the side, you've got the drug manufacturers. You also got your physicians and everything else. Well, whenever the insurer and the PBM are the same company, and they own pharmacies, they own, the big three own 80% of the market. This is CVS Health, United Health, OptumRx, and Cigna, who has Express Scripts. And whenever they have that, they can offer these bundled deals where they go to plan sponsors and they say, hey, we're going to give you this great deal on your healthcare benefits and your PBM expenses. And look at these rebates we're getting you. What you've got to do now is, we'll do that, but you have to mandate that you use the mail order pharmacy and our specialty pharmacy. And then they'll show, like, here's these non-specialty meds that if you go through the mail order, look at how much you're saving while doing this.
Yes.
And so they think that they're saving a fortune on regular meds, and their big expenses are like, oh, even though they're getting better net pricing than everyone, their big expenses are like brand name meds. And the biggest expenses are specialty meds. But what's happening increasingly is the PBMs are labeling non-specialty medication as specialty. There's nothing special about specialty meds. And they're requiring them to go there, and they're price gouging huge percentages. We're talking thousands of percent over the actual cost of these medications because they've labeled them specialty. So whenever you do that, you have vertical integration all throughout. You also have them buying up physician groups. You also have them now dipping into manufacturing. CVS right now is manufacturing a generic to Humira and claiming that they're going to bring down net costs for everyone by having this generic Humira. And guess what they're going to prefer instead of brand name Humira?
Their manufacturer.
Their own.
That is so scary and crazy that it's literally gobbling up the entire healthcare system.
They straight up are. And once they're done.
I have a question. Is that why? So, for example, I used to work at a different health system, and for that particular health system, they have one insurance, and they kind of require us to use their insurance.
Everything.
Is that what it's that part of that integration, the vertical integration then?
Yes, in a lot of ways with health systems, like if you work for a hospital and they have a pharmacy, they're going to do that to reduce their out of pocket because they don't absolutely need the PBMs. And they don't absolutely need like full-on insurers in a lot of ways. So they can break it up and keep their overall costs down. So you'll see that a little bit with those employers. And that's, part of the game. But that is not what the vast majority of people see.
Yeah. And it's like, I remember like one of my preceptors basically like that first described it to me. It's like they are the customer they are customer service, they are the boss, they are the complaint department. Everything is internal. And it's just, they are in line with the bucket. It doesn't matter what the assembly line is. They're getting paid somewhere along the way. And sometimes they're getting paid. There are two different buckets in one process line. Like, same process, but there's like 3 buckets, and they can disperse that money and hide it in all these different ways. It's the same company that is making money all throughout one singular process.
Think of it this way too. Your healthcare system, unless they have their own PBM, is still going to have to go through another PBM, because that's the only way you can get net pricing on brands, because they're the only people that have a kickback exemption.
Yeah. I guess my stupid question is, why are we scared that, or why don't we want a company like that just to kind of own everything? Because in my head, I'm like, oh, it's like one person kind of running everything. It's a streamlined process versus having to go over there for manufacturing, having to go over there for a pharmacy, having to go, it's like one company that's kind of managing all of that. Why are we scared?
Great in theory.
Yes.
The biggest thing is you can't expect them to act in good faith or really do anything that doesn't pad their bottom line.
Yeah.
We've seen it repeatedly. They'll come out and they'll say they're saving this much money. That's why Congress is so mad at them right now. They've brought them for hearings for years to see what's going on, and they've mostly trusted what they've said because they've been, allies to a lot of politicians throughout. They give money. But what's happened recently, like we saw in the hearing back in July, and that's why James Comer's so all over it. And whether you're Democrat or Republican or anything else, James Comer's all over it. He hates them. A lot of politicians hate them right now because they've drug them out in front of them forever. And a lot of times whenever lawmakers do that, it's kind of a heads up to them to just like, okay, you've made your profit. Okay, just kind of chill. We don't want to do this anymore. And they've repeatedly ignored them and just came up with bigger and more sleazy ways to make more money. And now it's at the point where they've made the politicians look bad. Like, they've made them look stupid in a lot of ways. And they're pissed off about it, as they should be. And so now they're just like, fuck you. No, we're not doing this bullshit anymore. No, hammer time. It's full on fucking hammer drop. And that's what's happening right now. And that's why I encourage everyone, like, now's when you get involved, because now might be the only time we have. Once they're done squeezing everything out of pharmacies, they're going to turn to physicians. And once they turn to physicians and they get enough market share, which they're getting a ton right now, once they're done with that, they're going to turn to the hospitals. You really want these companies that have been proven to be bad actors to run our entire healthcare system. We're already paying increased costs as is because they're artificially inflating things. Imagine if they have everything. Everyone needs to get involved right now and push back on it.
Yeah. And I think that's such an excellent point. We see it, but this is okay. We have to take a little bit of accountability here too, Jeremy. Like, we sort of kind of created this monster with the way pharmacists are just wired. We tend to stay quiet about the issues and just think that we can write letters and send letters and do Hill visits and make it happen. There's an example I remember in pharmacy school where nurses went on strike and jammed up physicians, like senators' phone lines. I don't remember any organized strike on our part as a profession like that ever. Like, we have an organizational issue and we have a synchronization problem, and we have to take responsibility for that. We're asking the physicians to step up for us, the nurses to step up for us, the big health systems to step up for us. But what are your thoughts on the fact that even within the profession of pharmacy and the way we think we need to go about this, everyone's not on the same accord with this?
No. And I'll go into it a little bit. Number one, I'm asking those people to step up, but not to do it for me. I'm telling them to join me. And that's one reason we're getting a lot of attention right now, is we're having a lot of patient advocacy groups and physicians and everyone else step up, like our protest at Express Scripts, our protest at Optum. That was us getting people together and really coming out. But it's hard for a lot of pharmacists to do that because in our contracts, we have gag clauses, including we used to have a gag clause where we couldn't even tell patients that it would be cheaper out of pocket to pay cash.
Yeah.
I never listened to it. I don't give a shit.
I'm shocked.
I'm
so shocked.
A lot of pharmacists are, scared of that. And so we finally got that taken down, but we still have a gag clause where we can't come out and say bad things about the PBMs, or we can't inform on the PBMs. They will come out and they will take our network contracts away. And so you'll lose a huge chunk of your patient base. So that keeps pharmacists kind of, down low.
Yeah.
And an issue is we've been afraid of that for years. And a lot of people have had their contracts ripped out, and a lot of people have gotten in trouble for it in the past. And those people, bless them, they laid the groundwork for me to come out and do my thing. Because now you can speak out a little bit. They'll send you a cease and desist, but if they press too hard and you've got the right connections, they're not going to do much.
Yeah.
That is such petty get it behavior. Out there. That is so petty.
No, it's
you
very
can't talk shit about
behavior.
me. Huh.
Yeah.
It just reminds me so much of Housewives. That's the inspiration.
Can
you imagine being like, oh, we can do business together, but you can't talk badly about me. And if you do that, I'm gonna make everyone hate you.
Exactly. Now it's a little more, they're not going to come back and do something so public. A lot of times they're going to come back and they're going to over audit you, or they're going to under reimburse you for your network. And they'll have to maybe true up at the end of the year, but they can underpay a pharmacy. And whenever it goes into your network performance or whatever, that's calculated continually across the entire network. So what you get back later, you're probably going to be underpaid compared to a a lot of the pharmacies in that network.
It's like pharmacy,
so
you've been
they
doing
can definitely
great.
Retaliate.
Like,
Jeremy gets retaliation. I can tell you that. But I don't give a fuck.
No, but like pharmacy, you've been doing great. But like, because you have been talking trash about us, we're just going to give you all this fees and not give you the reimbursement that you deserve. Like, that is insane.
Imagine? Yeah. And too, it's legal.
Yeah, it's legal for them. I would actually argue it's
legal
not
mean
legal.
Girls. That's what they
There's
are.
a reason the FTC is really bringing that hammer down, and that's because of a lot of work that we and a lot of other organizations have done.
Yeah.
And we need pharmacists out there speaking out. We need more people doing it. If they retaliate, what are they going to do? Pay us less? They're already fucking us. I mean, it sucks.
It sucks.
What's going to happen?
But
it's now or never, people. Like, we got to get co-sponsors on HR 9096, the Pharmacist Fight Back Act. That's how we actually rein them in.
Is there a way for pharmacists who are not necessarily, under a gag clause to also help and speak up, like help out?
Oh, we would love that. If anyone wants to get together and speak up, and I have a lot of pharmacists outside of retail that contact me all the time that are trying to get more involved and trying to speak up on this. And I appreciate that more than you all know. Like, I really do. I've never seen a time like this where it's really came together. A few years ago, if you would have said we would have got so many pharmacists and physicians and patients out in front of ESI protesting all together, that would have been like a pipe dream. So everyone's starting to come together. So if you want to get involved, you can come, you can join us at PUT. You could come, you can talk to me directly. Like, I'll find ways to put you out there and get on the front lines, even if it's just like spreading the message. We've got entire networks and state groups. We've got our national group. We've got everything else where a ton of owners are communicating, not even just about PBMs and best practices and how we coordinate to try to push back on this. We're also thinking about the profession as a whole, because what happens whenever retail all goes down?
Gosh,
there's not enough clinical jobs. No. Like, the market's going to get even more flooded.
But also, pharmacists needs to be in the community. Like, the role as a retail or a community pharmacist is just as important as clinical pharmacy.
It's critical.
If not even more. Like, you guys are, available for patients' access. Like,
it's critical.
It's critical. This is like life or death.
It's a huge issue, because a lot of times we're the only healthcare access that people have. And even when we're not, we're at least the most accessible. And we save the system a ton of money. And none of that's reflected because we've been undervalued throughout the years in this I'd call it a crusade to lower prices that has done the opposite.
Yeah.
We've got these companies, these vertically integrated middlemen that are making a fortune, and patients are paying more and plan sponsors are paying more, and they're doing it in the name of lowering costs and making patient outcomes better. And it's the opposite effect. We spend more right now on healthcare as far as prevention of fraud or cost savings or anything else. We spend more on that than we would just fucking paying. It's ridiculous.
Yeah.
Can you explain a little bit about reimbursement, like pharmacy reimbursement? What does that look like? And can you break it down a little bit for us to understand why it's gone down or what's going on with that whole process?
All right. Yeah. So, you know how we talked about brand drugs and rebates?
Yeah.
You know that list cost? That is what a pharmacy also pays. It's not like we get any of that. So
wait. Pause. I did not know that piece. Wait.
Yes.
Hold the bus. Pause. Right click right there.
Repeat that one more time,
please. And I need you to, I don't know why I'm shaking low-key, but hold on. That $610 that I'm coming in with compared to Thu's $100, that is what you also pay as a pharmacy?
Oh yeah, I've got to pay that.
There's no like, I thought there was like wholesale and stuff.
There's wholesale. That don't fucking matter. You think the PBMs are like giving me net pricing? That's not how that works. So it'll be listed at $610. I got to buy it for $610, and then the PBM will come in and will be like, well, we'll pay you $590 for it. And it's like, what the fuck? $590? And so we will lose money on these meds. And not just that. While we're submitting it, we have to pay a fee to actually submit it. So while we're doing it, we're paying a fee to submit it. Exactly. Yes. We also have to pay for our contracting to try to re-credential. And
wait, who are you paying? You're paying the PBM for contracting?
Oh yeah, we've got a. Now they're trying to charge pharmacists like $750, $500 just to re-credential to send them the same things we've uploaded to NCPDP and shit. It's fucking ridiculous.
So let me just get this straight.
Yes.
You pay. Okay, so let's just like use a full number so it's easy to do the math. But so let's say you pay $500 for a drug, and the PBMs will only reimburse you for $400, let's say. So you're already losing out on $100 by purchasing that medication.
Yes, for brand name drugs, especially with the injectables, like Wegovy and everything, it is not uncommon to lose $100.
That's wow. And on top of losing that $100, you're also having to pay the fee to
submit the claim.
And you're also having to pay the fee for the credential of being able to submit the claim. Is that what I'm understanding?
Yes. Yeah. On top of that,
they also come in. Housewives.
Yeah. On top of that, they will also come in later and audit you over these injections if you had a slight calculation that was wrong. So they'll come back and take back the full amount of a med you didn't make money on.
Jeremy, how do you guys make money?
We don't fucking make money. That's what we're trying to tell everyone. Especially on brand name drugs. If someone comes in with a brand name drug, outgrown, because we're not making money. Even on generics, we're lucky to make money because they've got so many other ways.
How much does the patient pay? What is the copay?
The copay? The copay is based on list price. So unless you've met your deductible, which most patients do not meet their deductible, they are paying a percentage based on the list price instead of the actual net price that has been negotiated for them. That's why HR 9096 is so important, because it's actually going to require that the PBMs apply 80% of all negotiations. That includes their GPOs offshore, every single thing that is part of a price lowering negotiation. They have to apply 80% to patient out-of-pocket costs and 20% to lowering premiums.
OMG. I'm still shook. I am still shook that that listing price is what you as the pharmacy is also paying.
Yeah.
When I am
Oh,
like,
let me throw in another little wrinkle.
please
So,
don't.
you
I'm
all know
still
about 340B, right?
Oh God, let's not.
I mean, I've heard of the term. Do I know what it means? No.
Okay, so 340B is when the drug companies donate like brand name medications to clinics or, 340B pharmacies so that they can sell it at a normal rate, and the difference, which they make good profit on, they get to take the difference and take care of the community for free. It's supposed to be a way to help like rural health systems and places that don't have a lot of money. It's a great concept. In reality, right now, the pharmacies open right now, 50% are 340B pharmacies. 75% of them are owned by either a healthcare conglomerate, Walgreens, or Walmart.
No,
Yes.
you're lying to me. You're lying.
Yes.
I don't
So
believe you.
they get the super cheap brand name meds that old Jeremy can't get. And get to sell them for over cost. And
so
they get to have these 340B contracts where they get a big chunk of whatever's left in the middle.
Yeah.
You guys, this is so horrible.
It's terrible.
The people who terrible.
You guys,
there's a reason we're screaming the way we are. Like,
I'm
screaming. It sounds like a lot of people encounter this and they straight up, like, for the longest time wouldn't believe us because it's just like, that can't happen. That can't happen in this country. It absolutely is happening.
And I think that's the part. That's why I keep saying, and it's all legal, because when someone who understands it explains it to you and they water it down to you, there's no way you can rationally think that it's legal.
That's possible.
But it is 100% legal.
Yes.
They are breaking zero laws. That's why, like, even to Jeremy's point, the senators are mad. The senators are upset. Okay, but sir, y'all are the ones who fell asleep at the wheel and let this thing go down and happen the way it did. We take responsibility for not speaking out. We take responsibility for not advocating and raising the funk when we smelled it on site. But reality is, lawmakers, this stuff went through. It's been going through. So, like,
that's because of MEGO, which I brought up earlier. They intentionally make it incredibly complicated. They use terms like AWP, MAC, WAC, everything else to really mislead everyone. They'll go to plan sponsors be like, we got you AWP minus 20% on that. AWP is a made up fucking number. Completely made up. Like, you know how AWP set? Whenever they upload their medications into the actual data bank, they set their fucking AWP.
Wait,
that's AWP how this works.
Actual wholesale, what? Pricing.
Average wholesale price, which is not the average wholesale price. It's not even close.
That's right.
It's a completely made up term.
Made up number. Yep.
Wow.
Yeah, so misleading metrics all across. And they'll use those to show, look at the discount we're getting you. Fuck you.
I'm truly heartbroken. Like, I have no idea that this has been so difficult to, keep an independent pharmacy because you guys are literally losing money to dispense some of these, some of it may not be life-saving, but some of it might be. And it's completely heartbroken to hear that businesses like that can't keep up with just the ridiculous competition and the power of those big companies. It's very upsetting. Hey guys, we're taking a quick break to thank you for listening to this episode. We're working hard to bring you content that is worth watching behind the scenes. If you find our work valuable, please consider purchasing our merchandise, friendship bracelets that are created to celebrate pharmacy friends. They are available on rxfriendsshop.com. This contribution will help us grow into an even better show for you. So as usual, we're glad you're here. We appreciate your support. Okay, back to regular programming.
Right now, pharmacists are being forced in a lot of ways to have 8 billion side hustles. We're being reimbursed on drugs, and they're constantly telling us, do more immunizations, do more clinical stuff, do this or that. Whenever, we're already overloaded. We're not getting paid enough to like have extra help to do a lot of these things. And so we're getting overloaded on a lot of these things. And the entire time I've been screaming through the roof, like, I'm okay with us getting provider status. I'm okay with us doing a lot of these things. We have to make sure drug reimbursement is good first, because now, just like I fucking told them for years, we're seeing that pharmacies right now, CVS Health is not giving pharmacies an administration fee for vaccines, because guess what? They want all those goddamn vaccines.
How
So pharmacies
rude.
now are just like, I'm not doing this because they're underpaying me, number one, on the vaccine, and they're not giving me an administration fee. So what they're trying to do right now is force us into taking as much physician market share as we can, because they know good and damn well they can force us to, and they know good and damn well once we take it, they can just not pay us. It's one of those things where I would love for us to do more, but it, in the overall scheme of what's going on, and that's why I have so many issues with APHA. They're finally kind of starting to get it. Shout out to Tracy Poole. You've done some great work there. Tracy gets it. A lot more of them are starting to get it. They've been pushing a lot of scope of practice, and NCPA has done it too, for years. And a lot of us have tried to tell them, a lot of us here on the ground level, like, listen, they're going to take advantage of us on this. Like, we have to shore up drug reimbursement and make sure that we have a baseline so that we can do some of this stuff and it not cost us on the other end. Because whenever COVID happened, pharmacies thought that we were making, pretty good money with the vaccines and stuff. They used that as a way to under reimburse us on our drugs while it was happening. That's when the huge cuts started coming in.
Wait, who's
so
they? The PBMs?
Undercut us. Yes, PBMs. So what happened was you saw
explain
the PBMs.
Explain that. Don't go too fast. Over
I literally
that.
am having like a stomach ache. This is so scary.
Yeah.
It's too early in the morning
really
for this.
But also at a time when the world is literally going to shit, they found a way to make more money. So please explain like how the pandemic kind of triggered some of all of this, because I think a lot of people just feel like, oh, pharmacists woke up during the pandemic, more of us came online, more of us became vocal, more of us, but there was something going on that was triggering some of this, what I think is a revolution for this profession, to be honest. But talk about like the significance of the pandemic and the things that started happening during and post-pandemic that has kind of led us here.
Yeah. Well, what happened was we went out and we were called upon because the chains, they could not get their shit together to get vaccines. Independents had to step up because they were just trying to figure out how much money they could make during this entire thing. And we stepped up and we're like, all right, we'll do vaccines. I didn't get paid for half the vaccines I gave out. I just gave them out because that's what's supposed to happen. We put our shit on the line over all of this. We worked harder. We came out, a lot of us got sick. I ended up getting like this post-COVID issue that I had a few months later where I had vertigo where I could barely walk for a month. It fucking sucked. And we did all that. And in the meantime, we're like, okay, at least, we're getting some reimbursement out of it, even though half our patients, we're not paying because that was part of the program. And there was a cash paying program where if you did this for patients that didn't have insurance, the government would reimburse you. Most of us didn't even know about it. And even if we did, it was too late. So I didn't know about that. So I was just out here doing all this shit. I got sick. I went in. It was a stressful time. We had all these fucking things up and it was kind of lonely in a lot of ways, except we had each other. And so we did all that and we think, okay, at least this is going to help because the PBMs have been cutting in big time with DIR fees and a bunch of clawbacks and retroactive fees. They've been doing that lately. And then COVID hit and it's like, well, at least this will shore up the bank account. Well, what they did during this was they knew that we were getting a bunch of extra vaccine money. So they took the opportunity to cut reimbursement to unsustainable levels so that they could get some of that back. Here's the thing. Once the pandemic was over and no one was given, 40 COVID shots every single day, the reimbursement got worse.
Oh my God.
So you had a ton of people who was out there grinding, doing everything. They started getting underpaid way more than even before they had. And while that's happening, you also have a bunch of crazy people telling you that you're putting poison in them it made a lot of people jaded. Believe it or not, I was way more friendly and unjaded before that. Like I fought against PBMs, but
can you imagine
now I'm
like
fucking shit. Like we do all this shit. The entire system has let us down. I don't give a fuck about anything anymore. I'm going to shove everything up their ass that I can. That includes litigation, that includes legislation, that includes the FTC. I will do whatever I fucking can.
I don't know if I should laugh or cry. Like I legitimately don't know how to feel. I'm terrified. Yeah. This is terrifying. What the hell? I can't believe. Yeah. And like when they just give you lower reimbursement, do they have to go through any kind of like transparency explanation? I mean, obviously I can already see your face.
They claim to. Here's the thing is they've got these things called MAC lists where they will pay you way under AWP, WAC, or any other metric. And they will say that, oh, well, the way we calculate our MAC list, it is actually proprietary, so we can't share how it's happening.
Oh, yeah.
They make it the fuck up is what happens. They just make it up.
The math.
And the thing is MAC challenges, you can submit them. They are rarely upheld. And so you can submit a challenge to it and they're like, oh, well, we can find this drug at this cost. Why shouldn't we pay you this cost? And it's like, show me where you can fucking find it. A lot of times they won't. They'll ignore your appeals. And if you can get a MAC appeal through, instead of applying it to the entire system, and we have seen this, a lot of times they'll just apply it to that pharmacy in particular. So they break a ton of laws. And because they're so big and so powerful, they can just dare everyone to come at them. They've got so much money, they're just going to tie you up in litigation forever. Plus, we have arbitration clauses on our contracts. And those arbitration clauses do not allow us to come together and actually sue PBMs. It's something we've been fighting in court for a while. We have to spend over 6 figures just to try to challenge a PBM on our own.
Yeah.
Oh my gosh.
I remember
kind of
someone explaining that to me because I asked, like, what if like a bunch of you just band together and did a class action lawsuit? And I remember her cackling in my face. Like she thought it was the funniest shit she'd ever been asked, because it's like, what do you mean we legally cannot form an Avengers group? We can't.
Because of the cost.
We're still doing it.
It's in our
We're still doing it. Mark Cooker out here, he's made a lot of headway against the arbitration clause. He's been challenging it in court because he sees what's going on with MAC pricing. And the funny thing is the excuse for MAC pricing is a way to make pharmacies shop around for the best deal. The fuck it is. While they have these MAC prices, they also prevent us from shopping around for the best deal. They're like, if you go outside of these particular wholesalers, we're not going to pay you. You got to send us your invoices and prove that you got this from our select set of wholesalers while we're actually looking for MAC pricing based off of whatever the fuck they want. We're fucked. That's what we're trying to tell people. We're fucked. We have to do something right now.
These contracts are obviously horrendous and the worst things I've ever heard. Why do pharmacies still, why are we still working with them?
That's the big question. We don't want to. We're kind of forced to. Okay. Whenever you have the big 3 PBMs that are all vertically integrated and all have 80% of the market, most pharmacies that are out there taking care of like rural communities, poor communities, most pharmacies even in rich areas, like I'm in Blacksburg, it's got a higher income. I can't go to straight cash because I wouldn't have the volume to sustain. Like as far as your net profits on it, you're losing money on most things and you might eke out a little bit. It depends on your drug mix. And so you have to roll the dice on these plans. You're forced to. Also, there's the fact that if you don't take some of these contracts, you've got to turn away people you've been taking care of for years.
That's right.
It's they play off our emotions.
Do people know, like, do the regular consumers know about these issues?
Mine do.
Yours do.
Probably
so
because
I'm in Blacksburg. I talk to them. They follow me. I'm also, known in the community, and not just the community, the sports community here. And so I have a lot of people from that follow me on various social media. So they kind of get that. Most people don't have that. It's harder to do. I'm also in a fairly highly educated area, like 2 blocks from Virginia Tech. So that I have people that can follow along a little bit and actually will get interested and like dive in. So my people do. But your general patient, they don't have time for that. They got more concerns. They don't, why would they? It's complicated. It's annoying. It's frustrating. It's better to just go about your day. And they want it that way because your regular patient, I don't blame them. I wouldn't want to care about this. You have someone come in and start talking to me about like the complexities of some other industry or something that I don't care. Well, I might care about it, but most people are like, I don't have time.
Yeah.
Like it's hard.
One of the most challenging times when I was still in AmCare is open enrollment for Medicare.
Yeah.
When I'm sitting there and I tell them what I used to do for my Medicare beneficiary is during open enrollment, I would send them a list of all of their active medications and tell them, go to the center, give them this list, make sure they help you pick a plan that is going to help make sure that what we went through this past year where we had to apply for assistance and do all this, you don't go through that, so they can help put you on an affordable plan. And they're always just like, I'm just going to tell them to give me whatever they gave me last year. Like, you're asking me to do too much. And I used to always just be like, but don't you want, there's someone that can help you pick up. So like to what you're saying is, I can't remember the last time during open enrollment at my job, I sat down to look at what are the changes in my plan? Do I want to change anything? I'm just kind of like, last year went pretty okay. My prednisone copay was $3. That was doable. I'm just going to renew everything, keep everything the same. And
they rely on
I know that things change. I know that like if I got put on something specialty, like all of a sudden I woke up one day and they're like, oh, your azathioprine is specialty drug. It has to go through a specialty pharmacy. And I'm like, it's what?
Yes, they can overcharge. It's ridiculous.
So you're telling me all of my transplant drugs, all of a sudden, or specialty, all of my transplant drugs have to be mail order. And it's a debacle because it didn't get here on time. I have to go pay out of pocket. Then like it is. And I'm a pharmacist and kind of can get on the phone and speak the language to a degree, right? So I'm imagining 70-something-year-old, the patient that's one of Thu's patients in the housewives, and like, so I can afford my medicine, right? No, I need a prior authorization. Like, I'm imagining because it's real. Like they are out here, they're clueless. And if you don't have a pharmacist like Jeremy that's just like, no, fuck that. We're going to apply for this, and they're going to mail it to your house for the rest of the year at no cost.
Oh, no, I won't point it to mail order. I won't do that. But no, full on, it's ridiculous because they intentionally target seniors, and we see this all the time. That's why in HR 9096, we've got this language where they're not allowed to steer or anything else, because even when a pharmacy's in network, they'll still send out intentionally misleading, especially whenever the patient has drugs that pay well, they'll send out intentionally misleading letters, and they'll send phone calls, and they'll do a ton of stuff to confuse seniors and make them think that they've got to go to mail order. They've got to do this when they don't have to. A lot of times they'll also throw up mail order opt-out where they have to call and they've got to stay on hold for 2 hours just to go ahead and say, oh, I don't want to get mail order. That is increasingly happening. And it's not just the under reimbursement. The thing is we have to hit them in so many different ways all at once to actually get them the fuck out of pharmacy. And that's why Pharmacist Fight Back Act is structured the way it is, because it's got all the benefits for patients with the rebate restructuring. It has anti-steering, anti-spread pricing. It also has the reimbursement reform, which is going to save plan sponsors a fortune and actually increase what independents are getting paid. We have a full-on goddamn winner that's going to actually save pharmacies out here. We need fucking people stepping up, whether you're in retail, clinical, anywhere else. We need you all stepping up and asking your representatives to co-sponsor this bill because it's going to save our profession. It doesn't have every single thing in a wish list you'd want, but this is going to stop the bleeding. It's going to stop us from dying.
How do we do that? Give us some actionable items today. Our listeners, they are mixed. We do have folks that are non-pharmacy that listen. Give us some actionable items at every level, beginning with getting more educated by following you and how they find you. But let's leave everyone here today with a step one on how we really can get this shit moving.
Yeah. The biggest thing is get involved. You know, you can join us at PUT. Follow me on social media. Get curious. I've, of course, got PBM on the rocks if people want to listen. It's also not everyone's cup of tea, which we interact with viewers and it's live. So we have one person talking about, well, you're not going to convince anyone with that language. and it's just like, this is PBM on the rocks. This must be your first time. Yeah. But it's really good. We bring on a lot of big names in pharmacy and get them on. I've had Matt Stoller on a few times with American Economic Liberties Project. Get involved. There's also the biggest thing right now is contact your representative in the House and ask them to co-sponsor the Pharmacist Fight Back Act, HR 9096. If we can get enough co-sponsors on this bill, it's going to move very quickly. We have a lot of big backing on it as far as lawmakers. They're starting to recognize the urgency. If everyone can call their lawmaker, and it doesn't take a lot of time, even if you don't have a lot of time and you can take, 3 to 5 minutes to call and talk to their staffer and voice your support, that still gets passed on. The more calls that they take for this, the more they pay attention to it. You don't have to go in like I do and set up all these meetings with lawmakers and, travel around the country and do all this. If you just give a little bit of effort, if everyone just does just a little bit, it really adds up to a lot. Like, I'm going to be out here fighting for you. I'm going to be out here putting in a lot of my time and doing a lot of these things. If you want to do that, fucking yes. Join me. I'd fucking love for you to. I'll get you as involved as you want to be. If you don't have time for that, if you can at least call your lawmakers or maybe try to organize a meeting with your lawmaker, it would go a long way. And if you need any kind of materials or background on any of this bill and why it's important or what it'll do, I have materials out the ass. I also have my own personal breakdowns on it that makes it a little more understandable, especially for people who are not as versed in the PBM language. So get out there, fucking swing. If we don't swing now, we're going to miss because we've got one window and it's narrow and we've worked really hard for years to open this. And we can't let Congress think they can pass like these little like transparency bills or fucking bullshit like that and think they've handled the issue because they've not. We've got to ram this right up their ass.
What is the timeline? What is the timeline that we're looking to get this bill through Congress?
The timeline on it is we are looking at it probably passing through the House early next year. It came online it came online late. That's a whole other story that I won't get into, especially publicly. But it came online this summer whenever Jake Auchincloss and Diana Harshberger came out and introduced it, and it was a fight for a year and a half to get it out. We were helping. Greg Reibold helped write the bill with APCI. Shout out to Greg. And we finally got it out. A lot of people did not think that it was a possibility just because it was so expansive in its scope. And maybe 2 years ago it wasn't. But now we've got such a spotlight on this that it has to happen. It's critical. Otherwise we die. So we've got it out there. We need co-sponsors. It's looking like a timeline of early next year. The great thing is once this is enacted, we can have language for it to go into effect almost immediately. So it'll save a lot of pharmacies. And the more co-sponsors we have, the quicker it's going to go through and the more pharmacies we're going to save.
Yeah. Thank you so much for breaking that down. This is can you say the bill title one more time?
The Pharmacist Fight Back Act, HR 9096.
I love it. Well, Jeremy, I am so grateful for you to come on the show. Yeah. And I know you have lots of fun plans afterwards, watching your mediocre football team win.
We'll see how fun they are.
We're
supposed to win. We'll see if we do.
Yeah, I'm rooting.
Maybe the refs will rob us again like they did against Miami last week. Fuck the ACC.
On another note, he's like, on another note.
One thing that I am so blown away by this story is that you have, really struggled through everything that you struggled through and still stayed. That to me means so much, and it inspires me to also want to get the word out about what pharmacists can do. Like, we don't have to run away. We don't have to change profession. No. We don't have to change what we do. We just need to look back and fight back. I'm really excited for this.
That's what we've had to do. Our backs against the wall now. That's what we have to do. Yeah. This is what my family does. I've got 6 pharmacists in my family. Like, what the fuck happens whenever they decimate it and pharmacy turns into some fucking corporate wasteland? Yeah. I'm not going to let that happen. And so if we're going to go down, I'm going to go down fucking screaming and swinging.
We appreciate the fight. We appreciate, and more than just appreciate, what we really need is for all of us to do our part in helping amplify this fight and the voices. And like he says, we need to swing now and swing up high and not just jabs. Need to swing.
There's no time for jabs anymore.
You better mean it.
Everyone's like, let's realign incentives. They don't fucking care. They're just going to come up with more shit. We've got to rein them in. Like, we've got to fucking pin them in and make them do this and make them go fucking elsewhere for their margin. Otherwise, we're done.
We're done.
Totally.
And thank you. I have to echo that note of gratitude from Thu for taking your Saturday morning to come and record with us and share your passion. What is clearly something you're passionate, and that it is personal for you. 6 pharmacists in one family. That's not just something you do because you're trying to make a living. It's a way of life. And we feel it. We want to do all we can to support that as fellow pharmacists. But thank you really for coming and educating us further today on this incredibly convoluted by design process.
Hey, you all are awesome. I love you both. I'm always happy to come on and mix it up with you.
Yeah, definitely. I love it. Next time we'll do like a nighttime one where we can't let our hair loose. It's a little too early.
And we'll bring glasses too. We'll bring glasses.
It's game day. The entire day is nighttime.
Well, thank you so much, everybody, for listening. If this episode speaks to you and you think that others may benefit from listening, please send this episode to them. It's going to help us reach even more people.
Yes, this episode will be available on YouTube, Spotify, and Apple Podcasts, or wherever you get your podcasts. You can connect with all 3 of us. Our socials will be linked in the show's description. Please, please, please look for Jeremy, the PUD, all of it, all of the things that he is doing and pushing. And we think that this episode, and have a lot of hopes that this episode helps really elevate the conversation around this topic and help elevate the conversation around our posturing with this issue, that I don't care what functional area of pharmacy you're in, it will affect our survival. And I think I would love to think that as pharmacists, we want more than just survival here, but we want this profession to thrive for the patients that we serve. Until next time, please don't forget it. We got this.
We got this, everybody.
Bye-bye.
Bye.
Oh, Jeremy.